Hello, 405. This is Sophia, and this is Lab 10, exercise prescription for special populations. Right, so the goal for this lab is to review the exercise prescription guidelines for individuals with metabolic and cardiovascular disease risk factors. So there is information lacking for chronic diseases and health conditions. So there are no very specific exercise prescription guidelines for individuals with these conditions. Thus, guidelines and recommendations for apparently healthy individuals may be used. But note, these can be used so as long as you adopt them and you tailor them to the individual that you're working with. So adapting them with good clinical judgment. So the guidelines and recommendations for exercise prescription for apparently healthy individuals may be used but adopted. The exercise prescription guidelines and recommendations are presented using the FITT principle. FITT stands for frequency, intensity, time, and type. So for this lab, we will review the exercise prescription for individuals with metabolic and cardiovascular disease, such as for cardiac diseases, and just general recommendations for exercise prescription, right, for the different types of cardiovascular diseases, such as hypertension, coronary artery disease. We'll also go over exercise prescription for pulmonary diseases, such as asthma, and the exercise prescription for overweight and obesity. So for the exercise prescription for cardiovascular diseases, there are different manifestations, right? So it's an array of conditions such as acute coronary syndrome, cardiovascular disease, cerebrovascular disease, coronary artery disease, myocardial ischemia, myocardial infarction, and peripheral arterial disease. So I will go over just the exercise prescription general guidelines for cardiovascular diseases. So cardiac rehabilitation is commonly used to deliver exercise and lifestyle interventions. And so the overall purpose, right, is this intervention is designed to reduce the risk, foster healthy behaviors and compliance to these behaviors, reduce disability, and promote an active lifestyle. Patients should be risk stratified as early as possible following their acute cardiac event or procedure in preparation for the initiation and prevention of physical activity. So this is the risk stratification system for individuals with cardiovascular disease. The American College of Sports Medicine, right, the ACSM, has adopted the risk stratification system established by the American Association of Cardiovascular and Pulmonary Rehabilitation, the AACBPR, for outpatients with known cardiovascular disease. So these include, right, this is in box 9.2 on your ACSM 10th edition guidelines. So no new or recurrent chest pain in previous 8 hours, stable or falling creatine kinase and troponin values, no indication of decompensated heart failure, and normal cardiac rhythm and stable electrocardiogram for the previous 8 hours. So I just want to go over very briefly some of the indications and contraindications for cardiac rehabilitation, right? So whether your client should start a cardiac rehabilitation program or not based on their current status. So some indications for them to start, right, is a stable angina or as highlighted here, right, other patients who may benefit from structured exercise and or patient education based on physician referral and consensus of the rehabilitation team. Some contraindications for starting the cardiac rehabilitation include unstable angina, uncontrolled hypertension, that is resting systolic blood pressure over 180 and or resting diastolic blood pressure over 110 millimeters of mercury. All right. So because an exercise test may invoke monetary costs to the patient in the form of meeting insurance plan deductibles and copays, an ordering physician or a mid-level provider may request that a patient participate in outpatient cardiac rehabilitation without an exercise test. Right? An inpatient cardiac rehabilitation program will be taking care of your physician inside the hospital and is monitored, right? But outpatient cardiac rehabilitation will be after hospitalization and taking care of other medical providers. So the following section on exercise prescription provides methodology for guiding exercise intensity when results from an exercise test are not available. So here they are. This is the FITT prescription for individuals with cardiovascular disease participating in cardiac rehabilitation, right? So take your time to go over the prescription of frequency, intensity, time, and type for aerobic, resistance training, and flexibility. But the ones that I want to highlight over are in the red crosses. So for the aerobic training, the frequency, minimally 3 days per week, preferably over 5 days per week. For the intensity, if you know that if an exercise test was performed, right, use 40 to 80% of the exercise capacity. But if there wasn't an exercise test being performed, then going through using the seated or standing heart rate at rest plus 20 to 30 beats per minute to prescribe the intensity, right, heart rate using the heart rate method or using the RPE method, 12 to 16 on a scale of 6 to 20. For resistance training, the frequency would be 2 to 3 non-consecutive days per week. Right? So non-consecutive means you training a day, then you rest, then coming train another day, right? Right, so for hypertension, this is chronic primary essential hypertension is defined as having a resting systolic blood pressure over 140 and or a resting diastolic blood pressure over 90 millimeters of mercury, or taking antihypertensive medication for the purpose of blood pressure control. So the exercise prescription for individuals with hypertension, although hypertension is not an indication for exercise testing, the test may be used to evaluate the blood pressure response to exercise. So this is useful to guide your exercise prescription, right? If you know their blood pressure response to the exercise, which we did in lab at the beginning of the semester, right? We studied the blood pressure response with increasing intensity of exercise. You may analyze the information, right? The recordings that you took of blood pressure throughout the exercise protocol and see if there's an abnormal response. So individuals with hypertension may have an exaggerated blood pressure response to exercise, right? Even if resting blood pressure is controlled, while they're exercising, you may see some abnormalities in their blood pressure response. And this may also be very similar to people with pre-hypertension, right? So exercise testing recommendations vary depending on their blood pressure level and the presence of other cardiovascular disease risk factors, the target organ disease or clinical cardiovascular disease, right? So you can see table 3.1 on your ACSM 10th edition to further use as a guide to do your exercise prescription. All right, so this is the FITT recommendations for individuals with hypertension. And from this, I want to highlight for the aerobic training, right? It goes a little bit very similar to the previous FITT recommendations. Frequency, 5 to 7 days per week. And the intensity is moderate intensity, between 40% to 59% of the VO2 reserve or heart rate reserve, right? Or an RP between 12 and 13 on a scale of 6 to 20. For the time, it has, should be, right? These are recommendations, over 30 minutes per day or of continuous or accumulated exercise, right? Accumulated just means they can perform a minimum of 10-minute bouts over a period of time, like throughout the day, right? If it's too strenuous physical activity at the beginning, you can break it down. If not, then about 30 to over 30 minutes of continuous exercise. And the type, right, it has to be prolonged, rhythmic activities using large muscle groups like walking, cycling, and swimming. Resistance training, 2 to 3 days per week, between 60 to 70% of the 1 RM and may progress to over 80% of the 1 RM. And so for older individuals and novice exercisers, they may begin between 40 to 50% of the 1 RM. All right, so for pulmonary diseases, chronic pulmonary diseases are significant causes of morbidity and mortality. Right, so there is strong evidence that pulmonary rehabilitation improves exercise tolerance, reduces symptoms, and improves quality of life. And there is scientific rationale that supports exercise training in people with non-chronic obstructive pulmonary disease, respiratory diseases, such as asthma, cystic fibrosis, and confirms similar benefits as those seen in chronic obstructive pulmonary disease. So for patients with chronic obstructive pulmonary disease, evidence-based recommendations and clinical practice guidelines indicate that exercise training should be a mandatory component of pulmonary rehabilitation. And so for asthma specifically, right, this is a heterogeneous chronic inflammatory disorder of the airways that is characterized by a history of episodes of bronchial hyperresponsiveness, variable airflow limitation, and recurring wheeze, dyspnea, chest tightness, and coughing. So the exercise prescription for individuals with asthma symptoms can be provoked or worsened by exercise, which may contribute to reduced participation in sports and physical activity and ultimately to deconditioning and lower cardiorespiratory fitness. So evidence for exercise training as an effective therapy for asthma is lacking. So exercise-induced bronchoconstriction, EIB, is defined as an airway narrowing that occurs because of exercise. So we have to be cautious about this. For athletes, like healthy individuals, this may also happen, exercise-induced bronchoconstriction, right? So it can be due to environmental triggers such as cold or dry air and air pollution, including such as allergens, right, and trichloramines in swimming pool areas that may stimulate a bout of exercise-induced bronchoconstriction. So these are the FITT recommendations for individuals with asthma. And so as you can see, for aerobic training, frequency 3 to 5 days per week, and the intensity beginning with a moderate intensity, saying 40% to 69% of heart rate reserve or VO2 reserve. And if well tolerated, you may progress all the way to 60% to 70% and progressively increase to at least 30 to 40 minutes per day. For resistance training, 2 to 3 days per week, and the strength training between 60 to 70% of the 1RM for beginners or over 80% for experienced weight trainers. All right, so for overweight and obesity, this is defined as a body mass index, right, between 25 to 29.9 and 30 or greater, respectively. For overweight, right, between 25 to 29.9, and for obesity, over 30. For all ages and ethnicities, overweight and obesity are linked to an increased risk of the development of numerous chronic diseases, including cardiovascular disease, diabetes, some forms of cancer, and musculoskeletal problems, right? So the management of body weight is dependent on energy balance that is determined by energy intake and energy expenditure, right? Exercise expenditure. So lifestyle interventions for weight loss that combine both reductions in energy intake with increases in energy expenditure through exercise are going to be your best way to allow or help that individual in weight loss, right? So a combination of both diet and exercise. So sustained weight loss of 3 to 5% is likely to result in clinically meaningful reductions in cardiovascular disease risk factors, including triglycerides, blood glucose, and HbA1c levels, and the risk of developing type 2 diabetes, right? So all of these can be ameliorated by just a weight loss reduction of 3% of or to 5% of their body weight, which is really good. However, due to low levels of fitness at the very beginning for those individuals with overweight and obesity, it may be difficult for these individuals to perform a volume of physical activity required to achieve that clinically meaningful weight loss. Therefore, the combination of moderate reductions in energy intake with adequate levels of physical activity is what's going to maximize their weight loss, right? So tailoring their food intake and increasing physical activity to their fitness level, right? So the ACSM position stand on physical activity and weight loss concluded that less than 150 minutes per week of physical activity promotes very minimal weight loss. Over 150 minutes per week of physical activity results in modest weight loss of 2 to 3 kilograms. And over 225 to 420 minutes per week of physical activity results in a 5 to 7.5 kilogram weight loss. So to promote long-term weight loss maintenance, right, progress slowly. Don't throw that individual into doing up to 250 minutes per week of exercise, right? Progress them slowly to get them to do that amount of exercise per week of moderate to vigorous exercise, and exercise and physical activity should be performed 5 to 7 days per week. Right, so these are the FITT recommendations for individuals with overweight and obesity, right? So for aerobic training, up to 5 days per week, and the initial intensity should be moderate, between 40 to 59%, and progress to vigorous intensity above 60%. For time, 30 minutes per day, that would be 150 minutes per week, and increase all the way to 60 minutes per day or more. So that, which would be about 250 and 300 minutes per week. And this should be prolonged rhythmic activities using large muscle groups. And for resistance training, 2 to 3 days per week, 60% to 70% of the 1 rep max, and gradually increasing to strength and muscle mass, to enhance strength and muscle mass. Right, so this is your lab manual submission. It's very straightforward. You're going to have to answer the following questions to determine if your client has major signs and symptoms suggestive of cardiovascular, metabolic, and renal disease. Right, you guys already determined this on the previous lab. Also, does your client have any atherosclerotic cardiovascular disease risk factor? Right, I'm looking at your table 3.1, ACSM 10th edition. You also answered this in the previous lab. And does your client need any medical clearance before engaging in an exercise program? Answering yes or no. After you've answered these questions, you'll be able to create your exercise prescription for your case study subject, right? So write down your unique FITT recommendations for aerobic, resistance training, and flexibility training. So please be specific and ensure you are using the appropriate recommendations based on the unique health considerations of your client. So for example, if they are obese and they have asthma, looking at those previous tables, the recommendations for exercise prescription, and tailoring those and creating your own right here. So filling out the boxes right here. And that would be it. Thank you for listening.